Welcome everybody. Today we are covering the subject of managing the drooling in the cerebral palsy, what could be done and what actually the way to interpret in a bigger picture. So what we're going to do, we're going to do it in the traditional format for our webinars. I'm going to share the screen, and of course our first help, or our first partner in that is going to be Mr. Google himself, right? So Mr. Google himself. Okay, so as always, we're going to start with asking the question to Mr. Google himself and see what Mr. Google is going to tell us. What are the standard versions which are being the explanations of the drooling problem, and what are the suggestions which the world leading experts that Mr. Google will quote for us. That's going to be kind of part one of our approach, and then after that we're going to look into the situation with some extra detail and say, okay, so what else can we do? So is there a way beyond the standard approaches and how we can achieve more? So that's our plan. All right, so therefore we open up with the standard way of doing things. So type into Mr. Google drooling in cerebral palsy, right? So you see there are offers here how to control drooling in cerebral palsy, causes of drooling in cerebral palsy, oral motor exercises for drooling, and so on and so on. So, and here right on top we have the first link, which is the link to the National Institutes of Health. So it's a PubMed. It's supposed to be the authoritative part. And then let's look here with the explanations which come from Mount Sinai Hospital. So the first answer, as we can see it here, is quite straightforward and quite simple, right? We just saw it. You know, what is the cause of drooling? It's the problems of keeping saliva in the mouth. All right. So far, that sounds like quite self-explanatory. You know, you don't need to have a world-class expert for this, from what I understand, right? So you see, you can kind of handle it yourself without any particular additional thing. So now let's see what else do we get. Do we have more explanations than problem with keeping saliva in the mouth? Well, we see that it splits into two big chunks: problems with swallowing and problem with too much saliva productions. So far, so good. So that's just a basic explanation. Now, let's press this button and see what we get here. Managing saliva control. Problems with the saliva control are considerable for children and young people with cerebral palsy. They are normally anterior, so that's a good phrase, right? So which you can link for yourself. Normally anterior, lost from the front of the mouth, but maybe posterior, with pulling of the secretions at the back of the throat, leading to coughing, choking, or risk of aspiration. So drooling or dribbling is the unintentional loss of saliva from the mouth. So look, this is essential. Now, I would say typically the parents pay attention to the things when it happens anteriorly, right, on the front. So when you see the actual dribbling and the extra saliva coming from the mouth. And I would say that things with the posterior, with the saliva accumulating at the back, it's not so frequently happening, and usually this is where it comes together in a package with dysphagia, right? So you see with the swallowing troubles, which comes for the food, the drinks, in particular. So, and here we have the explanations. Drooling is common in children with cerebral palsy for a variety of reasons. including abnormalities in swallowing, difficulties moving saliva to the back of the throat, poor mouth closure, jaw instability, tongue thrusting, lack of head control and poor posture, lack of sensation around the mouth, breathing through the mouth, and then excited and impaired concentration. So that's, in fact, as you look at this, that's a pretty good list, yes? So that's a list which is quite informative. You can see it's the swallowing itself, then even more specific explanation. Difficulties moving the saliva, fixed volume of saliva, difficulties moving it from the front to the back of the throat, then also poor mouth closure, right? So mouth closure as a property which requires which is not really saliva production related, right? So you see that's a property of the entire facial mechanics. Then there is the jaw instability, something that we also talk about, right? Tongue thrusting, another description which you are very much aware of, right? And then lack of head control and poor posture. Lack of sensation around the mouth, breathing through the mouth, excitement, and impaired concentration. Now, this is a very good example that in the medical type of texts, everything goes as a list. Like, you would have hard time making a big kind of coherent picture out of this, saying, okay, what's the core? What's the crucial thing? What's the kind of epicenter? How much of it is their actual original challenge? And then a cascade of the adaptations that the body is doing. And then as a result, you have the side effect, right? So you see, that's a very, very important thing. We might even jump on it right away, even before we go any further, because this is really a very, very essential part of the understanding. So see, for example, if we look instead of that first text, we look here and say, okay, so that's the neck, yes? So that's the neck, and then you have different layers there, so which shows us the mouth floor, the anterior neck, and so on, right? So, and then we hear the words such as the tongue thrusting, right? So you see the tongue thrusting would be the one related to what? So is it a separate thing, or is it something related to the bigger picture? Because again, you see here in this text, lack of head control and poor posture. And poor posture means usually just the curvatures which would be flatter or more bulgy, so which are different from the standard type of the curves, right? But lack of head control. So you see, tongue thrusting, jaw instability, lack of the head control, they all come in one package. Now, what would be the central point that we want to bring to your attention? So the central point that we want to bring to your attention comes from this, that in fact, you have to look at the big picture. And the big picture is, so this is the front view of the neck. This is more about the fascia layers of the neck. And here we can see it. So this is the cross section of the neck, yes? So the cross section of the neck, and this is where we are then becoming systematically fascial. So what does it mean, being systematically fascial? That means that we are looking at the key distributive properties, right? So you see how the things are spread. We're not talking about the specific anatomical units. So that's a very, very important thing about the fascia. So if you are speaking in terms of if you are really thinking in terms of the fascia, you understand that fascia is a mesh. Well, you can also say that it also looks like a mess, right? But in that sense, yes, indeed, it's a messy reality, but it's a mesh. And for, I don't know which time in my lectures here, right, I would remind this basic point that when we go to the videos of Jean-Claude Gumberto, which are demonstrating what's really happening under the skin, how it all works, right? We understand fascia is a mesh. It's this thing with thousands and thousands of fibers, which are nameless fibers. They don't have names. They only have this dynamics. You can't pinpoint an individual one and say, oh, that's the one, right? So that's why when we discuss the whole thing from the fascia perspective, that's where we start with this distributive global properties, and then trying to understand the big picture through them, whether they provide good enough stability as a basis or whether they're not. That's it. See, we are starting from one single simple premise. Everything for the body starts with the ability to self-stabilize and to be able to neutralize all sorts of the fluctuations which are coming from within, namely for the respirations, and from without, right? Changes positions in space and everything else. So you see the distribution of weights, the angles, and everything else. So that's really, really simple. So we remember this mesh. We go back to this picture, yes? So therefore, from this perspective, we're saying there is one first class of problems. This is the problems which are related to the cross-section and the mesh distribution within it. So that's a first way of looking. In other words, if this mesh, which consists of millimeters and then fractions of millimeters, which are then spread around, if it's not organized well, if it's not stabilizing things well enough at the level of millimeters per milliseconds, then the body will be in the position of doing something at the levels of larger scale, at the level of the individual distinguishable muscles, trying to deal with it. So in that sense, the core, the root, is going to be here. It's the answer to this question. Do we have a good enough underlying stability distributed through those thousands and thousands of elements and this millimeter per milliseconds rate? That's the central question. Now, within it, we can add one more set of understandings, which would be coming through some specifics of the layout, but first, again, as a general geometry. So what we see here in this general geometry is this. So what we see here is this. We have the cross sections. You see the cross sections, yes? So you see the deeper layers, you see the deeper ones, right? Then you see the larger ones, you see larger, and so on. So that's there. Those are the cross sections. That's the first point. And then we know also that when it comes to the cross sections, what is the rule number one that we studied in our webinar on torsions, right? So you see, because all the layouts that we have in the body, they are all torsional, right? They're all twists and turns. So what have we learned there? We have learned that, so you know that you control the torsion. You control torsion from where? You control it in the first place from the perimeter, right? You're not controlling it from the inside. So we can, of course, go back to this, right? And then ask ourselves to confirm this statement, which we'll do in a minute, right? But this is the first point. And then there is another thing which we have to take into account. Okay, how are the layers connected? What's the link between the layers? And that's the layout that we see here. So this layout that comes up through, so these are the layouts which are working inside and kind of being organized in this fashion. Yes, so you see that's this link, and that link tells us about this essential structure, which is called the nuchal ligament. Again, this is not new for you, so you have heard this from the webinars where we talked about the head control and so on, so that the head flexion is the primary basis, and the nuchal ligament, you might say, but well, Mr. Blyum, you are using now an anatomical name. You said that things should be nameless. Okay, true. I'm using the name here, but I'm using it as a label for this geometrical arrangement, right? So you see, I'm kind of using it more for the topographical references rather than to mess you up with this idea what kind of particular geometry this layout has. So if there is one name that we have to remember about the essence of the head control, right? So you see, that's this. So it's anti-torsion, and which is distributed over the perimeter and has to do with all these layers, right? And then we have the nuchal ligament, which is responsible for the deepest stability there. So that is a foundation of what comes as a head control, right? You see, and we are really, I must say that our conversation went a little bit off my original plan, as you can see, but it's also a great opportunity there. So if we do this, right, if we go back to our original text, and you see here, drooling is common in children with cerebral palsy for a variety of reasons. Abnormalities in swallowing, 1. Difficulties moving saliva to the back of the throat, 2. Poor mouth closure, 3. Joint stability, 4. Tongue thrusting, 5. Poor posture, 6. Lack of sensation, 7. Breathing through the mouth, 8. Excitement and the impaired concentration, 9. And then lack of head control, 10. You have 10 factors in a list. Now, if you were a parent, you look at this and say, well, if you are a parent, which you are, right? So you see, if you are a parent in a position to say, oh, what am I going to do with this? So it's, and if my child has this, and that, which of course is the case, right? You have pretty much all of those factors being very much present. Then what's the root? What's the out of this list? You see, they don't tell you in this list where is the horse and where is the cart, right? And of course, obviously, in this total thing, in this total list, there is a key word. And this key word is the lack of head control, right? So that's the really the big meaningful statement there. Because head control implies what? Implies the ability to self-stabilize, right? Self-stabilize, counteract external volatilities, instabilities, and so on. So self-stabilization. And then self-stabilizing through a wide range of typical situations, right? So see, through all of the other things. So in other words, it's important to understand, right, that the tongue is a separate thing. So in that sense, if you get something large like a tongue, the tongue always wants to thrust, right? So you have to include this into the package of the head control. You can't say, oh, that's a tongue is a separate way, right? So you see, it's part of the head control. So head control is a distributed self-stabilization, which at the same time is causing or costing minimal energy, and which is being distributed into their, if you wish, nameless, right? In the nameless way. So if you we put it in a nice way, it's kind of gets anonymized. So you cannot say who is responsible for the exact distribution. And then if you have that true head control, then all the 9 factors, they wouldn't happen. So you cannot use them in the same list. I hope that I'm making this clear. So head of control implies the ability to, it's a centerpiece of it is such a is stability which is good enough to provide for the independence and freedoms of all of those specific elements, which then in turn empowers those additional functions which are being described there. So that's really a very, very important thing to understand about. Because if we go back to our picture, so this is what we are going to see. So we want to focus on the truth and on a simple question. Do we have this good distribution? And do we have this additional cross-layered support, which would be embodied by the structure which is called the nuchal ligament? And if we want to look at it a bit closer, we are going to ask Mr. Google again, right? And we are going to see this typical picture. This, you see, that's a bad picture because it doesn't have the directions on it. So that's a good picture. So you see, this good picture is showing you that the nuchal ligament has this specific layout of the fibers, right? So you see, it's not just kind of neutral, but it has all these specific layouts which are going like this, like this, like this, like this, right? So you see, and then at the base, they turn the other way to provide for the ability to deal with flexion forwards. So that's really the key thing. What you want, you want to have this fundamental basis. Everything else is secondary. All the other things, they are coming from this, right? And again, what I'm giving you here, I'm giving you the mechanical, distributed, consistent explanation. I'm not giving you a list. I'm giving you one leading idea which talks about the relationship of the cross sections, which starts from the perimeter and as the leading one. Yes. And then I'm giving you the idea number 2, which is discussing the connection between those layers in a systematic geometrical way. That's it. We could have given it all sorts of names, right? So it's a nuchal ligament. Doesn't matter that it's called nuchal ligament. This is a it's a basically the structure which extra density which connects through their entire set of layers. So that's really the main point for the entire thing, right? And then everything else flows out of this explanation. Now, let's get back to where we started. We've got the list of 10 things. And this list of 10 things, what did we find? We found that the next question that comes there is some medicines commonly used in children, right? So you can also increase the amount of saliva production. Okay, so that's an important thing. So there are side effects to the so-called therapies which are being coming. So the consequences of saliva control problems are significant, have a major impact on the quality of life, family, carers, and so on. Well, then comes the whole social thing, description of the clinical evidence. Okay, so there are a variety of interventions used to try and reduce or eliminate problems with saliva control, including oral motor therapy, medication, and surgery, right? So you see, that's what we have here. So, but again, the logic is very straightforward. If you're using medication, that means that you're probably not doing things, deep enough when it comes to the therapies, right? So you see, and the very label oral motor therapy is already describing the things in a rather smallish way. So it's putting us inside the mouth. And, you know, if we are going to go back to our tools and say, okay, so this is the Z-Vibe, which we are now using very enthusiastically, right? But you look at this, you see what they're doing. These are the oral motor therapies. So you see there is always something that is going into the mouth. Yes? So you see more, you know, things which are done more, okay, sometimes a little bit outside, but mainly things are going inside the mouth. So that's really the oral motor therapies. But we already understood that things are, you know, they belong to a much bigger thing of the overall head stability and all the related factors. So now let's get back here. 4 studies. With regards to interventions in, you know, in medical speak, interventions, these are therapies. And the comparators studied, 3 studies look at participants who received botulinum versus those who received the placebo. It's already scary, right? So meaning, what is the botulinum? Botox. Yes, so that's already a poison. So therefore, by right, from the start, you know, you ask yourself a question. Can Botox, if we're looking back at our list, lack of head control, right? So we have a channel with the poor head control now, you know, which is already a poor distributed stability. Now, if I inject a paralyzing agent into this mix with relatively unknown distributions, right? And even if I'm lucky and it sort of stays locally, what am I doing to this big picture? Am I helping with the improvement of this fascial distributed self-support, or am I making an additional dent into it, or am I making an additional weakening of the total system, right? I think that the answer here is self-explanatory. If you inject poison anywhere into a weak area, well, what you're doing, you're definitely weakening the whole thing. So therefore, your so-called results, even if you somehow manage to block the excessive saliva production, that means that you've been actually, you know, that you are really looking just as a saliva as a specific clinical outcome. You're not looking at the bigger picture. So, and if at some point the channel would be losing the head position, if the channel would be getting worse in swallowing, or generally more spastic throughout the body, or yet worse in sitting, no one is going to be responsible for this. Because, well, look, this is a clinical assessment of the number of the saliva that comes out of your child's mouth. We measure it in terms of whatever milliliters per day. We've done this particular injection for you, and ta-dam, you see the percentage of overflow of saliva has reduced. Success. And that is going to be reported in the literature as a success. And also, I want you to learn how to read this thing. Right? So you see, like, if we have something in the same list, which is labeled as oral motor therapy, medication, and surgery, right? So what does it tell you? That if they are brought into the same list and the same kind of tonality, but it's progressively more intense intervention, right? More dramatic intervention. What does it tell you? So if you have a 3-step approach, which goes from milder and softer to more intense and intrusive, what does it tell you about the approach number 1? That most of the times, approach number 1 really doesn't work, right? Because if the less intrusive approach worked, then what? Well, then obviously, you wouldn't need to do next level of intrusion with the medications, right? And if the medications work, you wouldn't need to do the surgery, which kind of tries to do the, like, really do something more radical to the nerves or to the salivary, like, sensory system itself. So that's what has to be understood. So if the study is seriously discussing this type of the interventions, you would already know the answers to what the milder therapies are actually providing. And then what we have here is this. No comparative evidence was retrieved for the following intervention: physical, postural, oromotor, and orosensory therapies, intraoral appliances, and acupuncture. So in other words, what we have, nothing really works. So you see, there is no conclusive interventions or not conclusive therapies which would make any help on any local thing, right? And then you look here, you see, then in order to be able to compare the therapies and to know the outcomes, right? So the outcomes means results, which are listed in the protocol and agreed by the committee. So committee, the experts in the field, yes. So they give you their clinical importance for this outcome. So 2 points reduction, 3 points reduction, 10 points reduction. So these are three different measurement systems. But the thing is that as a parent, you might say, oh, wow, look, these people are actually trying to practice evidence-based medicine. So they're asking for the very specific outcomes. So it wouldn't be just some hearsay. It would be really specific, measurable outcomes. Isn't it great? So, and then aren't they concerned about all they're not just the therapies, they're looking at the bigger picture, right? See, that's what medicine takes. The consequences of the saliva control problems are significant and have major impact on the quality of life. They include the risk of social rejection, damp and soiled clothing, which actually costs you more, right? Tadam, unpleasant odor, irritated skin, mouth infection, interference with speech and eating and drinking, damage to the equipment, computers could be damaged, and communication aids. And this is incredible. This, when I started first reading medical texts, 30 something years ago, right? I couldn't believe this. This language has never changed. They just dump everything there in a list format, like social rejection, spoiled computers, mouth infections, and soiled clothing. They go in one package, as if they really meant the same from the standpoint of what it is for the child, for the dangers and so on and so on, right? So, but it's just a list. But the thing is that this is a paradox, really, in medicine because the language of the modern medicine is that, we are taking the bigger picture. We are taking a more comprehensive approach when evaluating the quality of life, right? So we're taking a more measured approach and we're taking a more comprehensive approach. So this is exactly your proof. So here we are. We have not one, but 3 different scales, which we can use for the measurement of the saliva production. And then those, we link them to the important quality outcomes, right? So it's a psychological well-being. So the child will be less affected by the drooling and the social context and so on. So, and once you put those together, what happens? Then your typical story becomes this. You, as a practitioner, you want to deliver measurable result as soon as possible, right? And then you start delivering things selectively, plus you get this idea, right? So you see, for example, if your child comes with all this list of the troubles, difficulties in moving saliva, poor mouth closure, jaw instability, tongue thrusting, and so on. So, and then somebody comes to you, see, look, Mr. or Mrs. Parent, I'm sorry, but we can't really fix all of those problems, since each of them is a selective problem in itself. And, well, it just would be too much of the surgeries, and we can't do the medications for this. But at least we're going to reduce the saliva drop. Ta-da! This is nicely measurable and is going to be comprehensive. You're going to get all these benefits. And that's really one of the challenges, because people ask me often, like, okay, what is the clinical evidence, that you have for ABR to prove your points, right? To prove your points on the statistical and other way. And the reality is, unfortunately, when you come into this pre-designed formats, you are in big trouble, because you see, they favor something which is easily measurable, and this easily measurable has to come within the time frame and then within a type of the scales that they have designed. And they have designed those ones for the purpose of working together with the surgical and medication tools that they have been using. So in other words, if you are competing in terms of time and in terms of the format of delivery with Botox, or with the surgical way of kind of cutting some of the nerve endings. So, and then nobody is going to care, and nobody is even going to understand your language that, okay, so the tongue thrusting, the jaw closure, the instability, the mouth closure, the jaw instability, and so on, they are all just being the sides of the same, of this, just different facets of the same issue. So these are different types of the desperate attempts of the body to compensate for those limitations, to compensate for one original source weakness at this level that we actually see. So, this return to this anonymized systems, to the nameless, spread ones, distributed, this is really creating a significant issue, because, it comes as a big trouble. And you see, in that respect, of course, we tried, right? We tried, and especially when it was 2014, 15, we made this major study, in Canada, when Mark conducted it, and we had everything done properly. It was like 200-page study with several hundred kids, and it was actually coming very impressively. But the reality is, we couldn't even publish it. It's been continuously rejected, not for the design of it, but for the premise. So some of them would sort of, they would rejected for the premise, what have you been doing? Or you've been doing some sort of their therapy which is seen as passive. So passive therapies are known not to work. Well, because you have it here, right? So you see, nobody is going to look for something new coming out of the home-based therapy, right? So you see, there were two big points. One is that, guys, where does it come from? Where your results are coming? Oh, home-based therapy. Home-based therapy. You don't have controllable environment, and on the one hand, so therefore your findings are inconclusive on the one hand. On the other hand, home-based therapy. How could home-based therapy by any means compete with a professional therapy? It's impossible. So therefore, you have a first level home-based therapy, you get rejected at that base. We're not just going to publish home-based therapies. And then you come into this thing, right? So you see, you just understood this from this current pyramid. See, in this current pyramid, we just read this thing very, very clearly. We understood that this is a 3-level pyramid, right? The 3-level pyramid. So it was, for example, here was the oral motor therapies, and those oral motor therapies are kind of physical, yes. So it's not medication, not the surgery. So delivered by the professionals. So it's a pro-level therapy. But you can see already the pro-level active approved therapy itself doesn't show any conclusive evidence. Now, the thing is that even though it doesn't show any conclusive evidence, the methods of those oral therapies, which are already in the systems and which are kind of done by the authorized physical therapists and whatever, so they will be done anyway, even though they don't show anything. But more importantly is this, it's just a stepping stone towards the two other ones, right? So you see, that would be medications and that would be the surgery. So therefore, when you come up and say, hey guys, I have the new therapy for you, which is home-based. But this home-based therapy, in terms of level of activity, it's actually a lot less active than what you've been doing here. So it's a more passive therapy. So it's not something that the child does, sticking the tongue on opposite, controlling the tongue, and so on and so forth. So you bring this description, what do you hear? You hear the phrase, we're not going to even waste the valuable time of our reviewers to review this type of crap. Because we have the really important things which are here, and you see even the intense versions like medications and surgery, they have serious limitations. What kind of thing you can expect from a home-based therapy? This is not professional, this is amateurs, and you are not doing anything intense. So how could it possibly work? So, and no one in those, when you bring something to a publication, no one is going to sort of sit and listen. Oh, look, but this is a bigger foundation, this is a bigger picture, this is a change of the worldview, and so on and so forth. No, they already, these things, they don't belong to the publications, and you are just supposed to contribute something in the small pieces somewhere here on all these parts. So you see, when you do these contributions here, yes, okay, you're going to be published. And you see, if you take whatever, 10 children, do some active exercises with them for 6 weeks or so, right? Measure the amount of drooling according to 3 different scales of drooling, collect the wet, the wet bibs and so on, and trust the parents just to measure the amount of saliva that the child was generating. So this would work. But if you come with something bigger, unfortunately, no. And look, you see, this is a challenging part, right? I'm clever enough and I'm realistic enough to understand, oh, Mr. Blyum, but this way you sound like a proverbial and classic case of a rejected genius, right? So you see who is just, trying to beef yourself up, but, in reality, you're just not having good enough and you can't deliver things consistently. That's why you're finding this type of lousy excuses and saying that the world is sort of conspiring against you. Well, frankly, there is no solid logical way to wash this type of stain off your reputation, right? So you see, if somebody says, well, you're just being a bitter person who is not delivering enough, and then you should do things, just do better, and then bring it better, and then, prove yourself and so on, well, what can you do? So that brings us back to the reality, and that's why we can see that even the entire sort of the problems in today's world, they are actually, like with rehabilitation, they're actually deeper. And that's one of my central points. In fact, rehabilitation, instead of being this far off corner as it is now, right? Because in fact, even when we're going to look at those cases, what happens? It's the same thing with seizures, or it's the same thing with droolings and so on. So, because like there would be labels there, no more wet wipes or something like this. So the whole conversation about the drooling, there would be a much bigger part, say the drooling in the regular toddlers, right? Or the child who is, I don't know, 1.5, and so on, when they're not supposed to drool and so on, they still drool, or they still have the pacifier and so on. So there would be a lot of this kind of much milder formats where there would be all sorts of how to train your child, how to show them how to whatever, how to train them with the spoon, with this and this. So there would be this much bigger use case established in much milder forms, and then the CP with all this 10 or more list is going to be there, like, oh, that's a really tough corner and it's very difficult over there, so, just be there. But the whole definition is going to be up in the regular people. The same thing with seizures, right? So, 90 whatever 5 or 98% of the seizure cases are the cases of the regular people, right? So you see, I mean, population-wise, it's okay. So it's it's a, let's say, half of the children with CP have seizures, right? But they themselves are 0.5% of population. So that's 1/4% of population with the seizures there. Okay, maybe 90%. So, and then let's say 2.5% of the population would have seizures once in a while, and so on and so on. And there are like hundreds of thousands of people, with their, and in fact, millions of people with seizures. So who then have them infrequently, and then the whole risks are going to describe what if you were just walking down the street and suddenly you had a seizure, bam, you crack your skull and then you are in trouble. Or you had a seizure whilst driving the car, and I think it's like about several hundred, maybe up to 1,000 cases in the United States alone a year when you have the fatal accidents because the people had the seizure while driving. So that's where the whole industry stands. That's where they design their tools. That's where they design their measurement systems and so on. And then, look, if you get to the child, and when you are a parent, even of a regular child, say, well, I've done some exercises, but then he goes to a kindergarten, and then everybody makes, and he's 3-year-old, and, they all laugh at him that he's, and call him whatever, a wet, wet Superman or whatever, like whatever, wet T-shirt guy, right? So you see that, and he's crying, and he doesn't want to go to the kindergarten, and then you have to go to work, and then and so. Well, why don't we do a Botox injection there, and then he's all going to outgrow it in a couple of years anyway? Ah, well, and then you do this and say, oh, look, okay, it kind of works. Ta-da! Here you have. And then all these cases with the CP, they would be going far, 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 far off. So, and that's how the industry, how the whole thought and everything works, right? And what my biggest statement altogether is about this, it's the wrong sequence. You have to start with the maximum challenge in the whole comprehensive thing. So because, all of us, we are based on this self-stability. So when you see, if you have 100% self-stabilization, you're not going to have anything, right? You're not going to have any visible troubles. So if you go down to 90% out of the list of the 10 that we just labeled there, or if we go a bit further, there may be 20 of them, right? So you might have one, but the other 9 would be sort of still hidden. So you suppress or chop one, and then, okay, it looks selectively as a single thing. So this person has a tongue thrust, this has this. So, like, and then if you have 80%, 70%, 60%, 50% of the capacity, then you're barely hanging on in this world, right? And then, like, the whole body becomes desperate. So it throws the tongue, it locks the jaw, it goes all, so that it reacts to any emotional volatilities and so on. It just exposes, right? So you see, like, if the sea level goes down, you get not just the biggest rocks showing up, but you start seeing all the hidden things. So that's really, unfortunately, a fundamental trouble, right? And that's what I keep saying, is that we cannot really treat the situation with the cerebral palsy in a standard way, as if it was just, okay, it's a complicated mix of all the other disorders. No, it's not. It's the foundation. And that's why the others should be seen through the lens of the CP. So not the other way around. So we should expect, so you see, like, it's a miracle why your tongue is stable, why it's not sticking out. It's a miracle that your jaw doesn't drop. It's a miracle. Because if it was just a muscular control, it would be that. That would be the thing. So in that sense, to understand that the child who sticks the tongue out and so on, he is normal in that sense. From the anatomical standpoint, he is normal. He's doing the desperate adaptation with the level of the big, relatively big centimeters. He's trying to use the centimeters in length, right, to deal with the milliseconds. And those two, they don't work. So you need the distribution to handle. So that's really the challenge, right? So, and look, it doesn't make life easier for you, but this is really the big picture, so that when we are digging into this big part. So this is where we studied all this stuff, right? So, and then clinical analysis profile, economic evidence. So let's do something less formal, right? So you see, this is kind of the golden standard, and this is really the academic people who don't touch their everyday life, right? So let's look further and see what else Mr. Google is going to give us. Okay, so let's do a simpler one, right? So high hopes, Dubai. Okay, goodbye, wipe attack, helping children to learn to control their own saliva, right? So you see, that's the message here. Tech. Drooling is the unintentional loss of saliva from the mouth and a common experience for very young children. You see, here we go. So that comes as a base, right? So you see, common experience for very children. All children, in fact, drool as part of their development. Controlling saliva is a skill that must be learned. See, right here, you get it. So you see, the whole thing, that's the foundation of everything. That, well, and then children need to develop a certain degree of awareness of their oral structures, hence oral motor therapy, right? I'm going to put the thing inside your mouth, right? So with different brushes and let you know, okay, so this is your inside of the cheek, this is your whatever, this is your cleft, this is your palate, this is whatever. Okay, put it on the map, hopefully it works, right? So, and then excessive drooling is often caused by poor swallowing. And then you have a more significant, right, things. Some conditions in which persistent drooling is commonly observed include hypotonia, hydrocephalus, genetic syndromes, and so on and so on. Who can help? Primary care physician, tadam, of course. Some children will need occupational therapist or physical therapist, and then speech and language therapist, and so on and so on. So that's this version of the explanation, but we have more intense versions here, right? So you see, which is really a great demonstration here, which shows you the salivary glands and the muscles on, but this person also gets the explanation, right? So you see, he also talks about the swallowing process and how often do we really think about the swallowing process. Swallowing is mostly automatic until one day we are no longer able to swallow. So in fact, swallowing is a highly complex process involving the brain, a set of at least 50 muscles, and some of our cranial nerves just to swallow one mouthful full of fluid or food. Amazing? I think so. Now, the thing is, that's not really so amazing the way that is that. It's important to understand that 50 muscles are impossible to coordinate, right? So you see, the person who does this thing is your child. They are trying to do it according to the book. And all the things which are coming with tongue thrusts and everything else, they are coming from this. So they don't have a distributed connection throughout. If you don't have a distributed, anonymized connection throughout through tens of thousands of the micro fibers or the millifibers that belong to the fascia, then you're going to be in trouble. And in fact, that is going to explain the issue itself. So, but as you can see, there isn't any good explanations or good kind of reasons. There's everything then comes up to this package that if you have problems, then you must have the issues to deliver this participation. So the tongue is unable to push the bolus of food, or unable to form the bolus of food, a delay initiating the swallowing process, filter fluid entering the airway, and so on and so forth. Right? Conditions, neurological, systemic, or structural. Disorders such as a stroke or brain injury and so on. So, and the take-home message, dysphagia is a symptom of the underlying condition and should be taken seriously, right? Dysphagia, problems with swallowing, right? And then speak to the ENT, ear, nose, throat specialist, speak to this specialist, so he's going to try to do something, but we already saw the conclusive article, well, I mean the overview article, that there is nothing really conclusive about the thing. So what we're going to do now, we're going to do this. We're going to look a little bit further and complete our story. So we're going to look here. See, there is a big other thing which is called very well health. So drooling, causes and treatments. Let's try to do the third take on the problem. Drooling, also called sialorrhea, right? So you see like diarrhea, that's leaking from the bottom. So this is leaking from the front. But you see, if you just call it sialorrhea, you're already sounding a lot more specific, right? You know, a lot more common. Drooling is common in several disorders related to the ears, nose, and throat. Yes? So right away, we understood there. Drooling is normal for all the children. It's part of the development. Young children. And here, ear, nose, and throat specialists. So you see, that's the way where the majority of cases are coming, and that's where the whole sequence is getting through. And in most cases, drooling is caused by overproduction of saliva, problems swallowing, and problems keeping saliva inside the mouth. And some people are at a greater risk of getting saliva, food, and fluids into their lungs, which can cause a serious problem. When to seek medical care. How drooling is treated. Treatment of drooling depends on the specific disorder and determining the root cause. For example, is drooling as a result of infection, antibiotics are used. And then, if drooling is the result of severe tonsillitis, the tonsils may have to be surgically removed. And in cases where the underlying cause cannot be cured, medications such as drops, spilled, and liquid medicine could be utilized to treat drooling. Scopolamine patches, glycopyrrolate, and botulinum toxin are medications that can be used to decrease the amount of production from the salivary glands. Severe cases of drooling can be treated with Botox shots, radiation to the salivary gland, and the removal of the salivary glands altogether. So that's what you see as the therapies which are being offered. So we looked at 3 or 4 different sources, right? And they just came up like with the Mr. Google. I didn't really do anything. That was what I got from the first page. Yes? So now we already went a little bit further with the whole thing, right? And understood that in fact the drooling itself doesn't really come as a separate point, right? So you see, with the drooling, we already understood this link. So one is the drooling itself, right? But then it also comes with the dysphagia, so swallowing issue, and we also understood that it comes in package with the head, neck control, right? So you see, that's these things are coming together. Now, in the head, we would then separate it into the ideas of the face, neck, well, and let's kind of extend it into the mouth, right? So you see this type of the relationships there. So that would be our take on this for now. But let me, first of all, just get here. So I'm going to show you several faces, yes? So you see, look, for example, you look at this kid, yes, and doing some drooling. You look at this kid, you look at this mouth, you look at this mouth. Would you be worried about this child? The answer is no, right? So you know, just by looking at this child, that yes, it could be teething, it could be whatever, you know, it could be part of the whole growing thing. Yes? Now, you look at this child, well, you know that this is, yeah, that's forever. This is a standard thing, and that's going to be there. Right? You look at this child, so the palette is slightly better, but overall you would understand that's the same thing. You look at this kid, it's a bit different, but again, it's obviously it's a different story. Yes, so you see, we're talking about the fact that you have the cheeks, you have somewhat better eyes, but you don't have the circles. But we will kind of get to this, right? So this one, you pretty much know that's going to be quite standard. And this kid, again, this would be a different story, right? So you see, because this kid seemingly he has the circles around, right? But he looks different in terms of the eyes, in terms of the jaw, and so on. So this kid is actually the one which would be more on the autistic side, right? You know, the expectations there, and the whole story would be a bit different. But my point is that as we look at the faces which are being presented to us as references for the articles about drooling. Okay, and I have two more here, right? So this one and this one, right? So now these ones we know that that's a completely different league. So this is what we typically would be expecting to see, right? So you see, and you realize what's the difference between this kid and not even that kid, right? But let's say when we look at this chap, right? So you can see right away that there are significant differences in the way how the child, what's the appearance of their entire face in general, right? Then the orbitals, then the big circle which goes through the nasal folds, and then the actual circle which goes into the mouth. So with the horizontal lines and with the vertical ones, and then the circle itself, right? So you see, for this kid, you see, he gets what looks like a horizontal smile, but the lips are very thin, right? So you see, and you would understand that, yes, this is a child who would have troubles in getting the mouth really well closed. But on the other hand, when we look at this child, everything is self-evident, yes? So what you are seeing, or to be precise, not seeing here, you are not seeing any circular controls from the cheeks and to the extended mouth. You're not seeing any lips. You're not seeing any control of the tongue. You're not seeing any control of the jaw. You're not seeing the visible orbitals, right? You're not seeing the lines at the forehead. You're not seeing the temples. You're not seeing anything there. Plus, of course, we can talk about the shape of the skull and then the neck over there. So that's the very first thing that we want to bring, is that if you have any kind of even basic experience in the subject, you already understand that, by looking at the children, we can make this progressive thing. So, and again, we might have trouble getting into this level of easily formulated progress things, as which were talked about, the studies and so on, and the reduction of the things here. Anyway, so that's my first point, is that what we know, like, we don't need a medical degree or a medical evidence to understand that, okay, this kid who has the proper presence of the lines, who have the proper depth of the orbitals, who have these massive cheeks, who have very well articulated chin, jaw, and so on. So yes, his lips are thin, but you see the division with the nose, you see the division with the chin, and you see the tight corners, you see the nice tongue. This is a kid where maybe, for whatever reason, right? So you see, there could be some sensory issues, or there could be whatever, right? There could be more tricky parts there, right? So you see, maybe he needs some awareness of the lips because they got somewhat off the map for whatever reason, right? We don't know. But this is where you can say, okay, let's do something. So you see, for this child, you don't need to do anything super big. So you see, this is all the ingredients are there, and you could be quite sure that for him it should work, right? But if you talk about a different category, if you talk about the children that we saw in the other pictures, well, the situation is very, very different. So what is the central message that then we bring to you through ABR? Saying, look, we are just putting things in sequence, right? And instead of making the list of those problems separately, we are looking at the point, at the whole thing, not from the perspective of how bad things are, right? Like measuring them from the bad, but we're taking the good, the depth of the good quality, right? So you see, we look at it at the depth from the stabilizing perspective, and then looking at the specific child, how close he or she is to this full size, fully developed matrix, right? So in other words, when we look at the situation and say, hey, this is a child at whom we look at, and then for him, you have all these factors, and then we take this child and saying, oh, if we look at this kid, right? So, and we put them together. So now what you can make very specific conclusions. Okay, so we want these corners of the lips to be more connected. We want the nose to be divided from the extended lips. We want the lips to be divided from the chin. We want the chin to be more articulated. We want to have the midline here, the corresponding cleft link. So we want to be there, right? So you see, we want to have the different structure of the lips, so that would be. Then we want to have the horizontal smile. We want to have the anti-drop of the jaw. We want to have the control of the tongue. We want to have those lines. We want to have those lines on multiple levels. We want to have those lines then we want to have these lines, and so on. So we can make an easy list of 12, 15 different things which are going to tell us, okay, that's how we convert, this situation into this situation. This is where we want to move the child, right? And that's speaking of this. So that's a strategy that we are delivering. Now, the thing is that if we look historically at the ABR thing, right? So obviously the tools that we are having today, these tools are way better than the ones that we had before, right? But the logic has always been very much the same. So we want to improve this total map of the underlying self-stabilization. So, and that's really it. So before we got into the percussion or the vibro tools, right? So you see vibro pen or anything, we were doing it manually, right? Long time ago, it was just manual. Then trying to extend the fingers, you got the eggs. So first it was the eggs which were the viscoelastic eggs of one brand. Then it's another brand. Then it's a third one. And then we found the eggs which were the foam eggs, and then the foam eggs of the different size. But then those were not giving us enough. And then we got the super eggs and so on. And then finally we found this, the Z Vibe as the micro cylinder. And then the technique, it was delivered one way, not controllable enough, then more. But the logic is the same, right? So we ask the same questions. Okay, you want to convert this kid more and more towards this one. Now you have, of course, lots of limiting factors. So these transitions, they take multiple phases, they take multiple stages. You have limits of the time, you have other commitments, you have, depends on how well the child is cooperating with you and all the other things. So it's not easy, but the fundamental map is quite straightforward. This is what you are looking at as a big picture. And then it brings us even to another important thing. When we see this big picture, then these measurements and the absolute numbers of the salivation, we are not particularly bound by them, right? Because you see, now we have to look at some other thing. So we now see the drooling not as a problem in itself, not in the soiled and wet clothes and spoiled clothes, right? We are not taking this aspect into account and saying, okay, dear parents, I hear your pain, you are so troubled in washing the clothes and they get ruined and discolored, right? So you see, we're going to try to solve this problem for you as soon as possible. Unfortunately, we can't to do it in this simple manner. So what we are looking at and saying, okay, so these are the constituent mechanisms. And to understand those constituent mechanisms, we have to understand where your child is. So, and for this, we now start looking at a more complex picture. So first of all, we are going to look at this one, which we had from here, this one. That's a great picture, right? Because effectively it's showing you what? It's showing you the location of the salivary glands, right? So these are the salivary glands. And then you see, okay, the salivary glands, they have specific locations. Okay, so now, if the salivary glands have the specific locations, that means that those locations, depending on whether they get the stimulus or whether they don't get the stimulus, that might affect the volume of the saliva produced by day. So, and if we look at the nice extended explanations by this gentleman, So he also highlights the fact that the salivary glands, they have the long ducts. Yes, so the long ducts, so you see that's the duct is a tube, right? So which the tubes which open in the floor of the mouth. So in that sense, things are long. So it's not just this, whatever, submandibular, sublingual, or parotid gland. So those ones also have the ducts. And when you see the face like this, you understand that this child is not having a very well organized mechanical environment for those situations. So in that sense, you might say, oh, with the mouth being so open and so on, it's likely to expect that, for example, these ones, the glands which are here, sublingual, so the ones which sits under the tongue, so this one might be overstimulated. But on the other hand, if you look at the child with this submandibular gland, he doesn't do any chewing, he doesn't do anything. So this one is actually a big question mark. So actually this one might be understimulated. Now, if you look at the jaw, if the child does a lot of mouth opening, so it could be overstimulated. But if the child actually is unable to do the big opening at the jaw and has more of the circular opening of the mouth, then on opposite, this is going to be understimulated. So we have this mix of potential situations. And that's really on the practical side. This is what we want to make sure that every parent understands well, that our big picture, the big picture, always comes back to this thing. Drooling, we are not seeing it as a problem in itself. Like, oh, we want to fix drooling. No, we want to address the fundamentals of the head control and the face control and rebuild this self-stabilizing matrix, which is necessary for improving the total control of the tone, right? So we always go back to the same thing. Muscle fibers are difficult to contain and control. The only way to contain and control them systematically is the way the Lilliputians control the Gulliver. Oh, not the Gulliver, right? So you see, that's the, yes, remember that? Gulliver Travels, the giants and the tiny Lilliputians. So the Lilliputians, anonymous Lilliputians, which are the fascia mesh, controlling and the big muscle fibers. So if the Lilliputians are not able to control the muscle fibers, then and only then the brain comes in and says, ooh, now I have to self-stabilize the muscle fibers. I cannot outsource this job. Now I start having problems and I start having like not so good solutions at the level of the muscles. I have to deal with it in big centimeters. I cannot outsource it to the level of the thousands and to the level of the millimeters. That's the problem everywhere. It's that simple. So what do? We just keep feeding the same thing. We want to improve the distribution through the meters. And that's the big picture. You know, on like I can go on into the details and so on of every kind of clinical situation, but fundamentally we're always doing the same thing, right? We are always passing the self-stabilization towards this fascia cloud or the fascia mesh or whatever. So the nameless, anonymized thousands and thousands and thousands and thousands per single muscle fiber. It's that boring of the process. And as we do that, we then achieve the transformation. So because again, the brain happily stops the over usage of the muscle fibers. If it's not necessary, it stops the insourcing if it can do the outsourcing. It's very simple, right? Because if you had, I don't know, a good enough vacuum, robot in your household, you would happily outsource any kind of domestic chores to this robot. And, instead of insourcing it, you would happily outsource it to the robot. The brain is the same. If the brain has to do all the kind of tough labor of doing the big things in the hand and controlling the muscles, only because it doesn't have this luxury of outsourcing it to the surrounding mesh of the fascial tissues. That's it. So, we always come back to this fundamental simplicity. So, and that's the map of the neck. But then, we also have then this conversation about the map of the face. And within this map of the face, we want to bring this component, which is really essential for understanding. So, for example, I'm going to take this kid, right? So you see, this kid is more a typical case, which looks more autistic rather than the cerebral palsy. How do you know this? So, knowing this comes from a simple fact. He has, in terms of the cheeks, right? So well-pronounced cheeks, good definition of the lips, and so on and so forth, right? But then, if you look here, if you look at the level of the transition between the jaw and the ear, right, and that whole level, so here it's all blurred. And you also see that the angle of the ear is kind of tilted further away. So that's this disruption, which is much more typical to, well, let's say if we talk about the children with the autistic conditions who then have some troubles with their endo, right? Not the meso layers, right? But the endodermal layers, difficulties with digestions, allergies, and all this other stuff, and so on and so forth. So that's a more typical situation there. And here we would see this. Why this is a good example? Because, for example, this kid has a good organization there. So the salivary glands, which is under the tongue and which is under the jaw, they definitely receive their good stimulus. But in his case, this big parotid gland, it's a question mark. Most likely it's understimulated. So, but also in the same thing, he would have, because of that weakness and so on, he would have troubles, really, as they say in one of these texts, moving the saliva which has been formed at the front, moving it to the back for swallowing. So therefore, it's much easier for him altogether just to let it out rather than bring it back. And if we were to start working with such child, we would be looking for what? We would be looking for the improvement of this division and the integration between the jaw and the skull, right? So we will be looking for that division and for that control. But what would that bring? That would bring two sides. On the one hand, we would be legitimately expecting that in a certain sequence of events, the child would be more likely to move the saliva through the mouth and into the swallowing. That would be a plus factor. But on the other hand, we might face the situation when that would bring additional stimulus, and therefore there would be even more saliva getting into his mouth, right? So you see, and that's, again, especially with the autistic children, we face this very often. So it's the ups and downs. And then the parents of these kids, these are the ones who have a more, shall I say, in their list of priorities, control of the drooling is usually higher, right, than for the children with bigger motor problems. And then it comes into this, oh, wow, he is, we started ABR and his swallowing reduced, right? So expecting us to celebrate, right? And then, oh, but now it seems to be worse again. So when you're judging those things just by the amount of saliva that is coming out, I understand all these complex things, right? Because again, for the autistic child, all that list about the wetness, about the fungus, about their spoiled clothes, about whatever the oral hygiene troubles and so on and so forth. I mean, they are all essential in their life, right? But we are working at the big long-term fundamentals. We're always doing the same thing. We want to establish the proper self-stabilization through the neck thing. We want to establish the proper self-stabilization through the face. We want to establish the self-stabilization through the head and their integration, and then getting the right sequence where the eyes would be first, the lips second, the neck the third. So that's what we want to do, and then coordinate and integrate it with the whole respiratory thing. So where it kind of comes into the next package together with. So that's the logic of what we are doing. And in that sense, that's why, similar to many other things, when the parent reports, oh, I am, so happy that with ABR, his drooling has reduced. I'm not going to jump and say, oh, wow, look at this. You see ABR works. This is great. This is great result for you, right? Especially if it happens early. Say, wait. It's a reflection of the bigger process. The way that it just shows that certain components are improving, that the swallowing mechanism, but since it's a mix of these two things, one is the saliva production, and two is the mechanics of the control of all the other elements in the mouth, the tongue, and so on and so on. So we have a lot of the things which might influence it in a different way. And we have to be all right about it. So there is nothing particularly like, yeah. Again, we'll have to look at the bigger picture. That's what I'm trying to say, right? And then here, I also had some other examples for you. So because if we look at the whole set of the neck parts, we also have to take into account this. This is a great picture. The great picture, which really shows you kind of a mix of the skull and the real and the muscular parts, right? And also you can see this is the person with the head elevated, so you can see the entire mouth floor base. That's what you can see here, right? So that's a really, really great picture. So we can see that the primary layout is actually working like this, right? You can see this set of the diagonals from the mouth floor to the hyoid, and then within it, so you see if you look further, so that part itself connects to another part, which is then going to be the transition to the lungs, right? But then this part itself from here also connects all the way to the nose. So that's a big picture. So, and in this big picture, what we are seeing these two things. On the one hand, yes, that's a great plan, the great realization there. And then it also helps us to understand one more level, which I didn't talk enough about today yet, right? I started with this conversation about the distributive supports in the neck, and then we moved into the recognition of the circular structures of the face, which is, again, not the first time we talk about it, the orbital versus the longitudinal ones, right? So this is, you heard about this before, but I want to highlight this, right? So what are the big thing that we always talk about, right? Our other big thing that we always talk about is that what is the number one function around which the brain organizes itself, right? And that number one function is the respiration. So that's our key point. Yes, so self-stabilization, that's a primary matrix, but whenever we talk about functions, not even the swallowing, not even chewing, not even whatever else, right? The primary thing is the respiration. And recently, and see, sometimes you forget things that you learned, I don't know how many years ago, right? And then recently I was reading a book about the development of the, basically how the animals turned from cold-blooded to warm-blooded, right? So you see the so-called exothermy to the endothermy. And then the guy there reminded that, well, that their amphibians, not only they are different blooded, right? So you see they're cold-blooded versus the warm-blooded, they are also having what is called the buccal breathing. So, and ta-dam, here you are. That's a frog. But I also found this wonderful picture here. This is the way how the frog does the inspiration and the expiration, right? And if you look at Mr. Google again, ask yourself the question, buccal pumping, it's even called, right? Buccal pumping is breathing within cheeks, a method of ventilation used in respiration in which animal moves the floor of its mouth in a rhythmical fashion. Yes? So, and for amphibians, this is the sole means of inflating the lungs. And now, what is the key thing for mammals? That they have the so-called costal breathing, right? Costal breathing, the costal breathing mechanism requires contraction of the intercostal muscles, and it's called shallow breathing and so on and so forth. But this is the key thing, to understand that it's the usual story. The usual story is this. It's not that they had the buccal breathing and then we have the costal breathing instead of it. The reality, it's on top, right? So you see, we have all the mechanisms of the buccal breathing, and then as the next kind of supercharging it, we've got the costal breathing on top. But the buccal breathing is primary. So that's why what we see in the kids as they are facing the crisis at the beginning of life, right? So they switch into what? They switch into the buccal breathing. So they use the pumps, and that's what we see, the cheek pumps, the neck pumps, the abdominal. And if you look at the frog map here, what you're going to see, you're going to see this thing, that this is the big set, this entire thing from here to here, right? So which would go from the chin to the pubic. So that's a primary set for the buccal breathing. So in that sense, this is a very important thing to realize, that this is not costal breathing when you would say, okay, so here are the ribs, there is the ribs, and then after the ribs you have the abdomen, so the person is then having some additional abdominal breathing. No, it's the not costal, in other words, ribs plus abdominal. No, it's the buccal, which includes the buccal, which is face plus neck. So, and then it includes this division, right? So you see, it includes the entire part. So it's this triangle versus this triangle. That's it. So in that sense, this part and then this part comes together versus the top part there on the face. So it's this and this. These are the two parts of the buccal breathing. So therefore, when you look at the frog, right? So you see, she's using this thing, but that's also what you need to, the cheeks, the nostrils, and so on and so on. That's what she uses to pump the lungs. And what you're seeing in the kids, that's what you have. So their mouth floor, their cheeks, and so on. In first place, when you look at the kid like this, you have to keep in mind he's in that state because his mouth floor, his neck is servicing this foundational buccal breathing. And unless we change the foundational things for the buccal breathing, higher levels, such as related to swallowing and so on and so on and so on and so on, they are not going to be addressed, right? So that's why this is really the key lesson and the key takeaway from our lecture, which is kind of already running into 2 hours. So where we want to highlight this important thing. So we are always coming back to very, very simple foundations. So one foundation is that distributed stabilization through the neck, which is easy to read. That will be the fascial mesh. And that's the thing. So where everything else related to the tongue or to whatever comes the swelling and all the other parts of this package that we saw here, right? So difficulties moving saliva to the back of the throat, poor mouth closure, jaw instability, tongue thrusting, and so on and so on. So these are the challenges which are stemming from the troubles in the head control, but that trouble in the head control in itself is going to be also linked, besides of the troubles of kind of original weakness in the development and underbaking, underformation in utero, it would also come as a part of this buccal a switch, a shift in the respiration where the child has to exhibit a significant contribution of the direct buccal participation, and hence, as a result of this, employ this entire set for their respiratory purposes. But by employing this set for the respiratory purposes, or employing it all the way from there, as we saw on the frog, right? So you see, including the shoulder girdle, that's a big picture there. So then this is a problem, because in order to do buccal breathing like the frog, you need to employ this part in the active fashion of the participation. And there are limits to what you can do throughout, because you are a human, not a frog, right? So you come up with the different presets, you know? So there's a limit on how you can expand. So therefore, that's going to change the rhythms, that's going to bring the additional mechanisms, that's going to do, and one of those, of course, is then going to be the transitions, for example, in the use of the tongue, right? And this is, well, you heard me talking about this multiple times before, because if we look at this set of the use of the digastric muscle, which goes from where to where, which goes from inside the chin, right, and all the way to the skull. But then, you know, it links also, you see here, it links to the hyoid bone. So in order to use this buccal mechanism, the child, since it doesn't have so much space, you see the frog would have the space here at the neck, but if the child doesn't have it, so what he's going to do, he's going to use the jaw a lot more as the way of doing this buccal pumping. But then what's going to happen? Then you need the tongue, which is attached to the hyoid bone, as an additional regulator. That's why you're going to see a typical story, the child doing the tongue thrusts and so on as a part of this whole combination. But then, of course, it's going to create its own issues with swallowing and so on and so forth, right? So the main lesson of today is this, is that you always need to look at the big picture. The big picture sits at the factors of the self-stabilization and the respiratory foundation. So if, and in that respect, once we understand those and the ability to switch to the buccal breathing, that gives us, or increasing percentage of the buccal breathing there, that gives us the explanation of why all these other things are happening. Swallowing abnormalities, difficulties in moving saliva from the front to the back, poor mouth closure, joint stability, tongue thrusting, poor posture, lack of sensation around the mouth, breathing through the mouth, and so on and so on and so on. So we would understand that those things are not independent, that they are actually the reflections of where, and they are not even being the problems in itself. They are being a really imperfect solution to the main problem that the brain is trying to solve: how to keep the person alive by providing their respiration 20 times per, 20,000 times per day. That's the foundation which is sitting underneath everything, including the drooling, right? But on the practical side, the thing is that once we understand it, we could be quite confident that this is something that we can reliably improve and reliably control, and what we can reliably track by using the key observations. The key observations being what's happening there with the evolution of the face. Are we developing the circular system and the deep rooting there, or are we not developing it, right? So you see, if we're developing, we're going well, because as we already understood from the very beginning, so in this system and the examples which were used for illustrating the trouble with the drooling, we have the kids like this, and like this, and we had this child, right? And it didn't take us long to figure out, okay, who is going to be out of the drooling problems quite easily and quickly without too much of there. But then this is really at the same time should serve as an inspiration for us, right? And this girl is actually a great demo, because once we've just seen this buccal thing, right, you understand now that the face is coming in the package with that neck part, right? So you see that that this is the extension of this big buccal package that she delivers throughout her face. So we are exactly having it as 2 hours. Well, that kind of turned out to be longer than expected, but I hope that we entertained the audience enough and didn't pull them to sleep too much, right? And well, for those who are watching us later, right, so you see, we're also inviting you to get further parts of the webinars which are exploring the everything related to the face coordinations, the swallowing, the eyes, and so on. So which are part of the same series, and effectively we're just taking the same big issues and showing their different facets that they have. All right. So I'll stop sharing on this, wave the hands, and we'll say goodbye to the Facebook people, and then to the viewers who are going to watch us in the recording later. So I hope that this has been informative, and of course we're always happy to receive your additional questions, comments, and so on, whatever you want to ask about your channel specific and how all that relates to your individual case. All right. So cheers and all the best with that.